Okay, hey everyone, welcome back to the channel. Today we are diving into some real cardiology exam cases on aortic stenosis and aortic regurgitation, all explained using the 2025 ESC guidelines. By the end of this video, you'll be able to confidently classify, interpret and manage every aortic valve scenario. Okay, let's dive in. The first case of a 62-year-old man presented to the cardiology clinic with exertional chest pain and dyspnea. His past medical history includes hypertension and gout, with current medication including amlodipine and allopurinol. The patient is currently vitally stable, however, there is an evidence of ejection systolic murmur radiating to the carotid. His echocardiogram demonstrates an evidence of aortic stenosis with a valve area of 0.8 and mean pressure gradient of 49 with preserved left ventricular ejection fraction. The question asked about the preferred management in this case. Before answering this question, let's review the aortic stenosis guidelines according to the ESC. The ESC guidelines demonstrate that whenever you suspect aortic stenosis, you have to evaluate the gradient across the aortic valve. High gradient demonstrated by high Vmax and high pressure gradients prompt evaluation of the aortic valve area. So high gradient and low aortic valve area, lower than 1 centimeter, demonstrate that this patient has a severe aortic stenosis. So we have diagnosed this patient with severe aortic stenosis. The next step is to how to manage it. Patients with severe aortic stenosis in the presence of symptoms requires evaluation by heart team regarding change of the aortic valve, either through surgical aortic valve replacement or transcutaneous aortic valve implantation. For instance, this patient has a younger age, low risk profile, therefore surgical aortic valve replacement will be the best option. Back to our case, we have this patient with a high gradient of 49 and low aortic valve area of 0.8 less than 1. Therefore, this patient in addition to symptoms, this patient will be for aortic valve intervention, and being of a low risk profile and less than 70 years, the surgical aortic valve replacement will be the best option. Okay, so the second question. We have a 45-year-old man who has presented to our care with a progressive dyspnea and exertion, orthopnea, and bounding peripheral pulse, a really query sign of aortic regurgitation, specifically severe chronic aortic regurgitation. On examination, he has a diastolic decrescendo murmur based here at the left sternal border, additional sign of severe aortic regurgitation. His echocardiography reveals an evidence of aortic regurgitation with EROA, which is equivalent to the effective regurgent orifice area of 40 with regurgent fraction of 61. The patient's aortic root is 40 mm and no other valvular lesions. The question asks about which of the following is the best next step in the management of this patient. Before answering this question, let's review the aortic regurgitation guidelines. Evaluation of patients with aortic regurgitation depends on qualitative, semi-quantitative, and quantitative assessment of the aortic valve. Back to the quantitative assessment, to accurately diagnose patients with severe chronic aortic regurgitation, you have to have effective regurgent orifice area of more than 30 mm. The effective regurgent orifice area demonstrates the size of the hole in which the blood regurgitates back to the left ventricle. In addition, regurgent volume of more than 60 ml per beat is considered a sign of severe chronic aortic regurgitation. Additionally, regurgent fraction, which is the fraction of blood regurgent back to the left ventricle, is more than 50% of the forward ejection fraction, is considered another sign of severe chronic aortic regurgitation. Okay, so we have diagnosed this patient with severe chronic aortic regurgitation. So what is the next step? Before going to the next step, we have to evaluate the patient's aortic root diameter. If the patient has aortic root enlargement, for this case, it should be more than 45 milli, you have to evaluate this patient for additional valve, with the additional to the valve replacement, you have to evaluate these patients for aortic root intervention. So if the patient has significant aortic root enlargement together with significant aortic regurgitation, you have to go to either Bental, which is the change of the aortic root and aortic valve, or aortic root change and together with aortic valve repair. So back to our patients. The patient has no other valvular lesions. He has significant severe chronic aortic regurgitation demonstrated by effective regurgent orifice area above 30 and a regurgent fraction of 61, together with normal or almost below 45 aortic root diameter. Therefore, this patient will go for surgical valve replacements only. Why? Because the patient is symptomatic and the patient has significant chronic aortic regurgitation. So the question asks us, what is the next step of management? Surgical valve replacement will be the only correct answer. So another question. We have this 68-year-old man who has presented to outpatient clinic for a routine follow-up visit. His past medical history is significant for type 2 diabetes and chronic kidney disease. The patient denies any dyspnea or chest pain with ordinary activity. However, his current medication is metformin and lisinopril. His blood pressure is okay, however his cardiac auscultation reveals an ejection systolic murmur, something query for valvular heart disease. His EKG shows an evidence of left ventricular hypertrophy. Okay, and his echocardiogram shows an evidence of aortic stenosis with mean gradient of 45 and left ventricular ejection fraction of 45 without any other cause of LV dysfunction. So the question asked about which of the following is the best next step in management. This patient is considered a severe aortic regurgitation. Although the aortic valve area is not mentioned, however, the patient has a high pressure gradient above 40. So we can conclude that this patient may have a severe aortic stenosis. Patients with severe aortic stenosis in the absence of symptoms should be evaluated by additional measures to evaluate whether this aortic stenosis is hemodynamically significant or not, even in the absence of symptoms. The first step is evaluation of the left ventricular ejection fraction. Having a left ventricular ejection fraction below 50 means this patient has hemodynamically significant aortic stenosis, severe aortic stenosis, with no other causes suggesting this low ejection fraction. Therefore, this patient with severe aortic stenosis have no symptoms, however he has a low ejection fraction, should proceed directly for heart team evaluation regarding valve replacement, either using transcutaneous approach or surgical approach. So back to our question, which of the following is the next step in management? This patient has a high gradient across the aortic valve. We have not mentioned the aortic valve area, however we will assume that this patient have a low aortic valve area and this patient is considered severe aortic stenosis, and he has a left ventricular ejection fraction of 45 without any other cause suggesting this LV dysfunction. So the best next step would refer directly for the valve intervention as this patient has a hemodynamically significant aortic stenosis. Okay, so the next question comes with a 58-year-old man with a long-standing hypertension. He is found to have a diastolic murmur at the left sternal border during routine examination, so the patient has currently no symptoms. However, he has incidentally discovered murmur. His echocardiography shows an evidence of aortic regurgitation with a regurgent fraction of 61, a bit high, and regurgent volume of 66 milli per beat, with left ventricular ejection fraction of 45 and left ventricular systolic diameter of 42. He denies dyspnea, chest pain, or reduced any exercise tolerance, and his blood pressure is showing 135/70. The patient's aortic diameter is 41. The question asked about what is the most appropriate next step in management. So for this case, before answering, we have to review the aortic regurgitation guidelines. The aortic regurgitation guidelines demonstrate that to quantitatively assess this patient to have a severe chronic aortic regurgitation, you have to have effective regurgent orifice area above 30, which is the size of the hole that regurgitates blood, and regurgent volume of more than 60 milli per beat, and you have to have regurgent fraction above 50. If you get this, you will diagnose with severe aortic regurgitation. Before managing aortic regurgitation, you have to evaluate presence of aortic root diameter. Presence of aortic root diameter in addition to significant aortic regurgitation requiring surgery. However, in the absence of severe aortic root dilatation above 45 milli, patients with severe aortic regurgitation should be evaluated initially for symptoms. Absence of symptoms means that you have to evaluate this patient additionally for the hemodynamic significance of this aortic regurgitation even in the absence of symptoms. So therefore, patients with severe aortic regurgitation without symptoms, however, with low left ventricular ejection fraction or dilated dimension, left ventricular systolic dimension above 50, should be evaluated for surgery and aortic valve replacement. Why? Because this patient, despite the absence of symptoms, have a hemodynamically significant aortic regurgitation, therefore requiring surgery. Back to our question. So the patient's diameter is 41, therefore he will not go for surgery directly. We were going to evaluate the symptom. The patient currently has no symptoms. However, he has hemodynamically significant aortic regurgitation demonstrated by low left ventricular ejection fraction below 50. In this case, it's 45. So the most appropriate next step in management will be an isolated aortic valve surgery. We will not go for pental operation as the patient's aortic root is less than 45. We will not go to transcatheter aortic valve implantation, which is class 2B in patient with a high surgical risk. Apparently this patient has no high surgical risk. And we will not continue medical therapy including calcium channel, dihydrobaridine calcium channel blocker in this patient, as he already has hemodynamically significant aortic regurgitation requiring intervention. So the correct answer will be isolated aortic valve surgery. So the next question, we have a 72-year-old female patient presented to the OPC with complaint of fatigue and shortness of breath on exertion. The past medical history is significant for dyslipidemia and her current medication including atorvastatin. Upon examination, her blood pressure is 140 and his cardiac auscultation reveals an ejection systolic murmur. His chest auscultation is clear, however his echocardiography reveals a preserved ejection fraction and a sclerocalcific valve with pressure gradient of 30 and calculated aortic valve area of 0.9. Further analysis reveals a stroke volume index of 42. The question asks which of the following is the best next step regarding the above patient's aortic valve abnormalities. Before answering this question, let's review the guidelines on how to diagnose patients with severe aortic stenosis. So, in patients with severe aortic stenosis of high pressure gradient, you will go directly for aortic valve area, and if the pressure is high and the aortic valve area is low, this patient is directly severe aortic stenosis. The problem comes when you have a discordant data between the gradient across the aortic valve and the aortic valve area. For instance, if you have a low pressure gradient and a low aortic valve area, this is currently considered a discordant data and you have to review yourself regarding measurements error. If you have excluded the measurement error, you have to evaluate next the forward ejection fraction across the aortic valve through evaluating stroke volume index. So discordant data between low pressure across the valve and low aortic valve area with adequate forward ejection fraction through the stroke volume index excludes the diagnosis of severe aortic stenosis. So, whenever we have a discordant data between pressure gradient and aortic valve area, the next step is to exclude measurements error and then evaluating stroke volume index. High stroke volume index excludes the possibility of severe aortic stenosis. So back to our question. This patient currently has an aortic valve area of 0.9 less than 1 and this is severe, and we have a pressure gradient of 30 mm mercury and this is low gradient across the aortic valve. However, her stroke volume index is of 42, which is higher than 35. Therefore, the next step that we have to conclude that this patient is not severe aortic stenosis and her fatigue and symptoms, shortness of breath, may be related to any other cause. Okay, the next question. We have this 70-year-old male presented to the OPC clinic with exertional dyspnea. His medical history is significant for type 2 diabetes and osteoarthritis, and his current medication is for metformin and occasional ibuprofen. His cardiac auscultation reveals an ejection systolic murmur, and his echocardiography showing what? Showing an evidence of aortic stenosis. His Vmax is 4.1 and mean pressure gradient of 42. Okay, and his calculated aortic valve area is 1.2. Okay, the question asks about which of the following is the next step in managing the above patients. Let's review the guidelines. The guidelines entail that whenever you have discordant data, you have to presume to exclude the measurements error. For this patient, we have this patient with a pressure gradient of 40, above 40, and Vmax above 4, so we have a high gradient. However, we have an aortic valve area that is normal. The next step is to exclude the measurements error, and one of the measurements error in this case may be related to hyperdynamic circulation, increasing the gradient across the valve, namely anemia, thyroid toxicosis, and any other cause. So whenever you have a discordant data, you have to exclude the measurements error. Whenever you have high pressures, high gradients across the valve with normal aortic valve area, you have to exclude the measurements error. Back to our question, which of the following is the next step? We have to exclude the measurements error and re-evaluate the findings. Okay, so here we go. Another question. We have 74-year-old male presented to the outpatient clinic with heart failure symptoms. His past medical history is significant for ischemic cardiomyopathy, and his current medication including aspirin, carvedilol, and Entresto, which is sacubitril/valsartan. Upon examination, he has a good blood pressure and controlled heart rate with a faint systolic murmur. His EKG showing a Q wave and his echo showing evidence of cardiomyopathy with left ventricular ejection fraction of 30. However, his aortic valve area revealed to be 0.7 and his pressure gradient of 22 and stroke volume index of 28. Okay, so we have discordant data between the pressure gradient and the aortic valve area, and we have also a low stroke volume index in conjugation with a low ventricular ejection fraction. The patient proceeded with a dobutamine stress echo that performed and revealed that stroke volume increases by 30%, reaching 60% at peak stress, and the aortic valve area remains of 0.8. So the question asks about which of the following is the best classification of the above patients. Okay, let's review the guidelines. The guidelines demonstrated that whenever you have a discordant data across the Vmax and pressure gradients, you have to go to evaluation of aortic valve area. Low aortic valve area in conjugation with low pressure gradients, you have to proceed to excluding of the measurements error, and if you excluded this, you have to evaluate the stroke volume index. Okay, so you have a low gradient across the valve, however, you have a low aortic valve area, then you are going to evaluate the forward ejection fraction through stroke volume index. Low stroke volume index mandates evaluating left ventricular ejection fraction. Why this? Because low left ventricular ejection fraction will act as what we call it like it misinterpret the gradient across the valve. So the gradient is low because the ejection fraction is low. The heart cannot pump this blood across the valve. So what we're going to do, we are going to calculate what is called the flow reserve across this valve. What we're going to do, we're going to have dobutamine stress echo. Dobutamine stress echo will assess the flow reserve. It's, for instance, it entails that the ejection fraction has to be increased above 10 to 15% above the baseline of this patient to conclude that this patient has a flow reserve. And then we are going to evaluate the aortic valve area. Achieving a good flow reserve, meaning increasing the ejection fraction with remaining low aortic valve area, mandate that this patient is severe aortic stenosis, and his low gradient can be increased with improving the ejection fraction, and this patient is severe aortic stenosis. So just to avoid missing, we have a high Vmax and high pressure gradient. We can conclude with low aortic valve area that this patient is directly severe aortic stenosis. However, if we have a discordant data between Vmax and pressure gradient being low, together with a low aortic valve area, we have to go to the stroke volume index, and if the stroke volume index proves to be low, we have to evaluate the left ventricular ejection fraction, and if the left ventricular ejection fraction improved with dobutamine and the patient's aortic valve area didn't improve, this concludes that this patient is severe aortic stenosis. So, back to our question. Which of the following is the best classification? This patient is considered severe aortic stenosis. Okay, another question. We have this 56-year-old man who has presented to our care with a progressive dyspnea and a decrescendo early diastolic murmur. Something suggestive of valvular heart disease, maybe aortic. His echocardiography reveals this flow reversal in the descending aorta, some hallmark of the aortic regurgitation. Which of the following represents a quantitative assessment of severe aortic regurgitation? Before answering this question, let's review the guidelines. The guidelines demonstrate that if you want to evaluate severe aortic chronic aortic regurgitation, you have to have a qualitative assessment, semi-quantitative assessment, and quantitative assessment. For quantitative assessment, you have to have the effective regurgent orifice area above 30, and you have regurgent volume above 60 milli, and you have regurgent fraction above 50. Effective regurgent orifice area is the size of the orifice that regurgitates blood, and the regurgent volume is the amount of volume of blood regurgent during each beat, and regurgent fraction is the fraction of blood regurgent with each beat of the heart. So effective regurgent orifice area above 30 is considered a quantitative assessment of chronic severe aortic regurgitation. Back to our question, we have the patient's pressure half time. Pressure half time below 200, which is here as 150, is one of the semi-quantitative, not quantitative, semi-quantitative assessment of severe chronic aortic regurgitation. Regurgent volume of 40 milli per beat. Its quantitative assessment, however, is a bit low. And vena contracta of 5 is considered one of the semi-quantitative assessments. Therefore, we have this effective regurgent orifice area of 50 centimeter per second is considered the single best answer for this case regarding severe chronic aortic regurgitation. Okay, another question. We have this 80-year-old female presented to our OPC clinic with annual checkup. She's feeling well with no symptoms. Her past medical history is significant for osteoporosis and hypothyroidism. Her current medication are aldronate and levothyroxine, and upon examination her blood pressure is okay and her heart rate is 68. Cardiac auscultation reveals an ejection systolic murmur, and his echo pack is Vmax of 3.4 and beam region of 30. Her aortic valve area is 0.9 and the stroke volume index is calculated to be 33. Which of the following is the best next step in the management of the above patient? Okay, let's review the guidelines. We have this patient who have a pressure gradient of less than 40 and Vmax less than 4, so we have a low gradient across the aortic valve. However, we have the aortic valve area of less than 1. So we have a discordant data. The next step is to exclude the measurement errors and go directly to the stroke volume index. Stroke volume index below 35 will mandate evaluating left ventricular ejection fraction. Why? To exclude the effect of left ventricular ejection fraction as a part of the contributor of this high or low pressure gradients. So back to our question. The patient has a Vmax of 3.4, which is low, and mean pressure gradient with 30. Both of them are low of the threshold to diagnose aortic stenosis. However, here aortic valve area is 0.9 less than 1, which is suggestive of aortic stenosis. A stroke volume index is calculated to be 33, which is below 35. Therefore, the best next step is to evaluate the left ventricular ejection fraction. Okay, here we go. The last question. We have 65-year-old man presented to the outpatient clinic for evaluation of severe aortic stenosis that is detected incidentally. He denies exertional dyspnea or chest pain, so the patient currently has no symptoms. His past medical history includes hypertension and COPD, and his medication including bisoprolol, this is well controlled, and tiotropium. Upon examination, the patient blood pressure is 140/70 and his heart rate is 80. His cardiac auscultation reveals an ejection systolic murmur. His EKG shows sinus rhythm and LVH, and his echo shows an evidence of severe aortic stenosis with preserved ejection fraction. So we have a patient with severe aortic stenosis and preserved ejection fraction, and he's currently have no symptoms. However, during exercise, the patient blood pressure falls by 30 millimeter mercury. The question asked, what is the next step in management? Before answering this question, let's review the guidelines. The guidelines demonstrated in patients with severe aortic stenosis, the first next step is to evaluating the symptoms. In the absence of symptoms, you have to consider that the left ventricular ejection fraction, low left ventricular ejection fraction below 50 without any other apparent cause will mandate concluding that this patient's severe aortic stenosis is hemodynamically significant and requiring evaluation by heart team. However, in the absence of low left ventricular ejection fraction and low symptoms, you have to further evaluate this patient for the hemodynamic significance of this severe aortic stenosis. One of them is exercise assessment. Exercise testing that with sustained fall in the blood pressure below above 20 millimeter mercury mandate that this patient have a severe aortic stenosis that is hemodynamically significant, and if the patient have low procedural risk, he can proceed for intervention, either surgical aortic valve replacement or transcutaneous aortic valve implantation. So whenever you have severe aortic stenosis, you have to evaluate symptoms. No symptoms mandate evaluating left ventricular ejection fraction. If you have a good ejection fraction and no symptoms, you have to evaluate the hemodynamic significance of this severe aortic stenosis. If the blood pressure during exercise decreases by more than 20 millimeter mercury, and if the patients develop symptoms during exercise, this mandate that this patient has hemodynamically significant severe aortic stenosis, and if the patient has acceptable procedural risk, he can go for intervention. So, what is the next step in managing this patient? The patient has a preserved left ventricular ejection fraction and severe aortic stenosis. However, his blood pressure falls by 30 millimeter mercury. Therefore, we have a hemodynamically significant aortic stenosis. Apparently, the patient has no severe symptoms. His COPD may be considered a query for high surgical risk. However, in this case, I will proceed with valve intervention. Okay, so we have done. Thank you very much for listening. And then high-yield aortic valve cases decoded using the latest ESC guidelines. I think the amount of information is enormous. Remember, these golden rules, they're before evaluating any valvular heart disease, you have to evaluate symptoms, and if there is symptoms, you have to intervene. You have to evaluate ejection fraction, and if ejection fraction is low, you have to intervene. Whenever you have discordant data, you have to verify. And the root dilatation changes the operation type in case of severe aortic regurgitation. If you found the breakdown helpful, hit that like button and subscribe for more cardiology case mastery. Thank you.